So colleagues, I was asked just to give a very short welcome and start us off with a very quick poll. And I will then ask Dr. Nana Poku from the Ghana South-South Learning Network team to take over this meeting and take us through this. So just a very warm welcome to everybody who's joined this Link and Learn session today. Personally, I find these Link and Learn sessions incredibly valuable, and we really welcome the leadership and the guidance and learnings that are provided by the host country, in this case, Ghana. And we welcome colleagues from other South-South Learning Network countries to this call. So just to start us off with an icebreaker, the Ghana team were kind enough to provide an icebreaker question. And Lulama, perhaps I can ask you just to launch a quick poll that we'd like to use to start off this session.
I've shared, Carrie. Is it showing on your side?
No.
Not yet. Okay.
Yes, it is. We can see it.
Oh, you can. Sorry, maybe it's just me.
Okay.
Sorry, Saul. Thank you for that. So Lulama, maybe you can relaunch, or if it's launched, we'll just allow colleagues a minute or two to complete.
Your colleagues are still voting. So maybe after we have more than 50%, we can close the poll. We are at 52% of attendees who have voted, Carrie. 60% now.
Thank you, Lulama. Maybe you can share the results. It's just really to give us a taster to start off the meeting.
Sure. These are the results. It seems like the top choice is cultural, traditional, and partisan influence, followed by health worker stigma and discrimination. I hope everyone can see that.
Thank you, Lulama. I think that's a nice prelude into the rest of this Link and Learn session. And so with that, Dr. Fred Nana Poku will take us through the remainder of the session. So over to you, Doctor.
Right. Thank you very much. And then we want to take this opportunity to welcome everybody to this learning section. The Ghana team, as you can see on your screens, composed of a mixture of both different participants from different work sections. We have government, we have civil society organizations, we have international NGOs and then local NGOs. We are here to discuss some of the issues surrounding key population programming that we have and we try to solve. And we are always trying to identify and find solutions to the numerous problems that affect our programmings. And today we are sharing some of these experiences. We are not saying that we have all the solutions or we've overcome our problems. There are still challenges, but we're working hard to ensure that these are overcome. So these are the team members. Myself, we have Senor, we have Dr. Jane, we have Ifu Agri from USAID, we have Della Gale, we have Claudette, we have Gertrude, Kofi, Egbert and Kojo Kodia. As I said, from Ghana AIDSCommission, Ghana Health Services, civil society, and from local and international NGOs, and the UN system as it is. Next slide, please. So we're going to have 3 sections, part 1, part 2, and part 3. I'll just be moderating the section as it is, and Mr. Kofi Diaba, who is from West Africa Program to Combat AIDS and STIs, will take the first section, telling us about what is happening in country, the context in which we are having our implementation, and then it will be followed by some of the issues that we have tried to solve, the steps we've taken, how we got to do this, and then some of the challenges that we face. So without much ado, I will call upon Mr. Kofi Diaba, who works with the West African Program to Combat AIDS and STI, to take us through the first section of the presentation. Thank you very much. Kofi, over, please.
Thank you very much, Dr. Nana Poku. So once again, good afternoon. My name is Kofi Mawena Diaba, and I work with WAPCAS, West African Program to Combat AIDS and STIs. So I'm here with a team, and I'll be doing this presentation with my colleague Egbert. I do the first part, and he comes in with the second part. Please, next slide. So basically, we are starting off with a contextual overview of HIV and KP programming in Ghana. And as we all know, we are looking at bringing AIDS to an end, but we still have Ghana as one of the countries that are behind in terms of HIV new case reduction, accounting for one of the countries globally. Another thing that is critical to know that the HIV and TB interventions service delivery in Ghana are human rights related, have human rights related barriers that limits access to services in terms of HIV prevention, treatment, and care support services. And these services, these barriers affect the key populations and the vulnerable populations disproportionately. And we are also looking at Ghana as among one of the 20 countries prioritized for the Breaking Down Barriers project, which is funded by the Global Fund for AIDS, tuberculosis, and malaria, which is supposed to help remove human rights related barriers to accessing HIV services. Next slide. Now, in terms of HIV situation or overview in Ghana and the KP programming, HIV was first reported in Ghana in 1986. And since then, we have continued to record cases. Since the time the case was reported, the first cases were reported, the country has used a multi-sectoral approach in trying to address the epidemic. And basically based on the UN 3.1 principle, the one coordinating body, which is the Ghana AIDSCommission, which is a commission established by an act of parliament It was actually established in 2002, but there was a new act in 2016, which was Act 938. And then we have the One National Strategy, the National Strategic Plan for HIV, which is the latest one, 2021 to 2025. And then we have one national M&E plan that is looking at this strategic plan. Currently, Ghana is estimated to be about 31 million people, with about 374,000 persons living with HIV. National adult HIV prevalence is 1.70, and according to the Demographic Health Survey, the national prevalence was 2.0. This is from 2014. And then the national prevalence, that is the 1.70, is from the national estimates process that is coordinated by the Ghana AIDSCommission. We do have regional variations from about 2.66 to 0.6 prevalence in the regions. What this tells us is that all the 16 regions of Ghana have recorded cases of HIV. Now, for key population prevalence, we have 4.6 at the latest study that was conducted in 2020. And then for MSM, we have 18.1 from a study in 2017. Prisoners also 1.8% prevalence from a 2019 survey. Next slide, please. This slide basically is trying to look at some current figures in terms of the PLHIV population and looking at the cascade up to viral suppression. And so with that estimate, as we have 346,000, we have about 69% knowing their HIV status. And of that, about 96% are on ART as of December 2020. And of that, 73% virally suppressed. So these are figures coming in as at the end of 2020. Next slide, please. So this slide is also looking at key population performance on HIV prevention services. You have the estimated population, the numbers reached with services, and then the numbers testing for services. Then you have the yield, the numbers that are HIV positive, and of course, numbers enrolled or linked to treatment. For the FSW, we have an estimate of about 60,000 as at now from the last survey that was conducted, and 44,000 of these female sex workers were reached, with 39,700 testing to know their HIV status, of which 2,237 were positive, giving us a yield of 5.6%, and 2,138 were linked to treatment. In the case of MSM, which is on the right side of the slide, the set of bar chart there, also giving us about 21,270 of the 54,000 being reached with services, and 94% of that who were reached testing to know their HIV status. Yield amongst the MSM testing was 2,153, a 10.8% yield, positivity yield of 10.8%, with 1,968 being put on treatment. Please, next slide. The program as we have as a country is primarily guided by the National Strategic Plan, which of course gives direction as to what has to be done as a country and for which particular groups. And there is a comprehensive provision of HIV and AIDS prevention, care, treatment, and support to all who need it through the strategic policies, the programs that we have, which are very structured, guided by the strategic plan, and of course, the procedures and activities do have a structured arrangement. These policies are regularly formulated and updated to align with global directions and country capacity. So, as a country, Ghana is very, very abreast with latest guidelines in terms of provisions from the WHO and other technical support groups. And so currently the test and treat, for example, is in place, ensuring know your status differentiated service delivery is being rolled out seriously across the country. The arm of the Ghana Health Service that is leading the agenda for HIV treatment program is the National AIDS Control Program. So as a country, we have the AIDS Commission, which is more of a supra-ministerial organization that is responsible for policy and other issues, while the National AIDS Control Program, it's more of the technical arm for the provision of HIV-related service. And this NACP is with the Ghana Health Service, or it is an arm of the Ghana Health Service. In terms of the programming in Ghana, there are several guidelines and documents and SOPs that are developed with specific indications. Example, the human rights strategy. We have the key population standard operating procedure for implementing the HIV interventions. We have a differentiated service delivery guide, and also a tax sharing policy and all of that. Currently, Ghana is also adopting and rolling out best practices to complement existing activities and interventions. So we have HIV self-test and PrEP that has been rolled out, specifically targeting key populations in the interim, and lessons learned being learned from there to be expanded to the general population later. Next slide, please. Now, in terms of our key population interventions or programs, these are mainly led by civil society groups or civil society organizations. We do have both international and local civil society organizations that are leading this agenda. For example, you have WAPCAS, you have WAF, you have JSI, which is an international NGO, and other government agencies with technical assistance and financial support from development partners and then UNAIDS. Civil society groups work within communities and collaborate very effectively with health facilities, whilst also operating drop-in centers or like safe houses or safe spaces. And there is such collaborations with Government of Ghana entities, the Ghana AIDSCommission, NACP, the Gender Ministry, SHRAJ, which is the Commission on Human Rights and Administrative Justice, and other law enforcement agencies like the Ghana Police Service. And of course, we also have private sector participation in whatever is being done in country, across the country. In terms of the HIV services that are being provided, a combination prevention mix is happening in Ghana. You have HIV services, HIV testing happening, public education, behavioral change interventions, condoms and lubricant distribution and promotion, and of course, also linkages to care and support. And as mentioned quite recently, PrEP for key populations also. Then we do have some community care and support services to help with tracing defaulters in terms of treatment, and then provision of safe places for persons who are abused or want a place to hide from perpetrators of abuse. And then we do have KP empathic health facilities and healthcare workers. And these are facilities that are KP friendly, and KPs feel comfortable going to these facilities and these specific healthcare workers for services. Now, we also have human rights and stigma and discrimination intervention happening to reduce and or eliminate the barriers related to service uptake. You have things like the M-Friends and M-Watchers, and also sensitizing the law enforcement like the Ghana Police Service, and then of course bringing on board SHRAJ, the Commission on Human Rights and Administrative Justice, to ensure that all persons whose rights have been abused can access justice. There are several capacity building programs ongoing to support interventions, especially for key populations. You have curriculum reviews, training of trainers, and rolling out of training for healthcare workers, for law enforcement, and even the community volunteers. So we do have peer educators and navigators. We do have case managers and models of hope. Mainly the models of hope are persons living with HIV who are identified and trained to support the community of persons living with HIV. Now, our implementation strategies always consider the traditional social and cultural inhibitions, our sex taboos and anonymity expectations as far as possible. Next slide, please. So what has informed our human rights response to HIV interventions? In 2017, a national baseline was conducted, and this brought up issues that really were critical in terms of access to healthcare services. And key findings include high levels of stigma and discrimination against key and vulnerable populations, issues of social exclusion, self-stigma, service provider bias, and demonstration. Then, of course, the legal environment, punitive laws, policies and practices leading to police and community harassment and violence against FSWs and other key populations, cultural biases and gender inequality leading to gender-based violence and intimate partner violence, economic and social inequality. Now, it is clear from the assessment that certain key and vulnerable populations, including younger female sex workers, younger men who have sex with men, and some street children are particularly susceptible to financial hardships, which tend to aggravate their vulnerabilities. And then poor knowledge about HIV/AIDS leading to poor attitudes towards PL/HIV. Next slide, please. Now, the other thing that informed our human rights programming is that the 2017 assessment, human rights assessment, actually solidified findings from the demographic health survey that was conducted in 2014 that showed a 67.7% who were showing signs of stigma, responding no to the question, would you buy fresh vegetables from a shopkeeper or vendor if you knew that this person had HIV? So a lot more people showed that stigmatizing attitude in their response. On all the four indicators that measured stigma associated with HIV and AIDS, only 8% of women and 14% of men aged 15 to 49 expressed accepting attitudes towards persons with HIV and AIDS. The assessment also identified existing interventions by government and civil society groups like WAPCAS, WAPGSI in response to recognized challenges. Next slide, please. So the response to the human rights issues come under 6 very broad pillars under the interventions that we are having and the strategic plan developed. Basically, the human rights issues have been classified under coordination, and this is mainly being played, this is mainly a role being played by the Ghana AIDSCommission in coordinating all human rights intervention, leading the advocacy for reformation of laws, regulations, and policies that are relevant to HIV. Please, I'm having some feedback. All right. The other pillar is the elimination of all forms of stigma and discrimination targeted at PL/HIV, people affected by TB, and other key and vulnerable populations. This is where the stigma reduction activities are carried out by civil society groups, by government entities, by all partners and key stakeholders in reducing stigma and discrimination. Then we have the pillar of promotion of access to justice. And here we are looking at all the activities that will lead to access justice in terms of legal support, where you have pro bono lawyers, for example, supporting the key and vulnerable populations should they have issues or human rights abuse cases. And then we also have interventions under that to look at legal literacy, where we are looking at building the capacity of the community members in terms of their rights. The next pillar is looking at removal of gender-based barriers to human rights and healthcare service interventions, and also to eliminate TB and HIV-related gender discrimination and violence against women and adolescent girls. One of the critical things that was identified from the human rights assessment was the healthcare worker-related stigma and discrimination. And so there is a pillar on building capacity of healthcare workers and managers on HIV and AIDS and TB-related stigma, discrimination, and human rights barriers that affect PLHIV, people affected by TB, and other cases. And then the last but not least pillar is the reduction of stigma and discrimination relating to practices and activities in religious, faith-based, and traditional settings in respect of PLHIV, people affected by TB and other key and vulnerable populations. Next slide. The strategic plan, the human rights strategic plan as developed, was actually led by the Ghana AIDSCommission, the coordinating body for the HIV response in Ghana, with support from the joint UN programs on HIV and AIDS Ghana office. A consultant was procured to facilitate some consultative meetings and the drafting of the strategic document. Was also constituted with representatives from relevant government agencies, with civil society groups and all, including stakeholders and implementers of HIV and TB interventions, as well as members of networks and associations of persons living with HIV, persons affected by TB, and other vulnerable community members. After a draft of the strategic plan, the document was also shared with some other consultants from the UNAIDS and the Global Fund, who made very valuable inputs into that at various stages of the whole strategic document development. And at the end of the day, the steering committee organized all the stakeholder engagement to participate in the validation for the adoption of the strategic plan. Next slide. So we are looking at factors that are facilitating the implementation of the human rights response to HIV. First, we are looking at issues of advocacy, which is to get the buy-in and embracement of this plan for its successful implementation. Specifically targeting stakeholders such as those who fund and those who provide technical support to come on board through direct and indirect advocacy and engagement on issues that were outlined. For example, to mobilize political support for the implementation and sustainability of the Human Rights Strategic Plan and the overall HIV response. So advocacy to also refocus political attention on the specific needs of key and vulnerable populations, in particular adolescent girls and young women, and to develop specific programs to attend to them. To publicize the strategy to engender stakeholder understanding of issues, the complexity of the challenge, previous international attempts, current planned implementation approaches, leadership and coordination mechanism. And of course, to establish linkages among local level institutions, implementing human rights and gender-related health interventions, and to coordinate their activities effectively for a more national response. Also, advocacy to facilitate reviews of laws or the call for new legislations when needed, and to push for revisions and implementation of relevant policies and enforcement of laws that address stigma, discrimination, gender-based violence, and human rights violations pertaining to PLHIV, people affected by TB, and other key populations. Next slide, please. Currently, some laws, the national HIV response actually has government approval by the passage of the Ghana AIDSCommission Act, the Act 938. And this act enables the development and implementation of appropriate HIV and AIDS prevention, care and treatment, and human rights supporting policies. It enables the coordination of all stakeholders towards national objectives and plans, enables the monitoring of the interventions, and it helps with the mobilization of funds to support the HIV response. And basically to say that an AIDS fund was actually part of this new act. Several policies like the STI HIV policy, anti-stigma policy, workplace policy, and the budget line in district assembly common fund budgets exist to actually support implementation. Now, what we look out for is to have further advocacy for an increment in the percentage of the fund earmarked for the purpose of HIV and AIDS interventions at the district level. The district common fund, that advocacy is ongoing to have that percentage increased. Next slide, please. HIV and human rights. So where do the two meet? Basically, we are seeing that the marginalization that these key populations face, or persons who are abused face, actually impacts on the choices they make in terms of their self-care and development. So the National Strategic Plan for HIV 2021-2020 is actually an overarching strategy that recognizes this challenge and it directs interventions to address these. Then we have the Human Rights Strategic Plan that also responds to the desires to achieve stigma and discrimination reduction, health rights awareness creation, and to evolve a conducive enabling environment for the provision of HIV and TB related care. The Human Rights Strategic Plan and the NSP are very complementary in implementation and also in approach. Now we have the strategic plan covering 2021 to 2025 and the Human Rights Strategic Plan covering 2020 to 2024, and it's expected to form the basis for advocating for the incorporation of more pragmatic rights and gender-based approaches and interventions into both upcoming TB and HIV strategic plans. Next slide, please. So in terms of the human rights strategic plan, some key outcomes are expected, and we are looking at the end of the day, the number of laws, policies, and regulations that have been newly enacted, that have been amended, reviewed, or reformed. Looking at percentage of peer educators of PLHIV, persons affected by TB, persons with disability, persons who inject drug, trained under the new curriculum, who are actually providing targeted interventions and services in each region. We are looking at percentage of young persons who successfully access TB and HIV-related human rights and anti-discrimination interventions. Curricula of judiciary and police training aligned to current laws, policies, and guidelines, and then appropriate human rights empowerment information packets developed and disseminated to targeted communities like PLHIV, persons affected by TB, and other key and vulnerable populations. We are also looking at the end of the day that patients, clients are empowered and they are actually utilizing grievance procedures instituted in various healthcare facilities and statutory organizations such as SHRAJ to report issues of stigma and discrimination and human rights violations. And number of PLHIV care and support volunteers, example models of hope, case managers acting as champions for media and number of institutional human rights and anti-stigma campaigns. We are also, at the end of the day, looking at patient complaint forms disseminated and grievance decks established for redress in all health facilities and relevant state institutions. And all of these outcomes are being monitored through programmatic reports, and some are based on periodic surveys that will be conducted according to the M&E plan for the strategic plan. Next slide, please. At this point, I would now want to hand over to my colleague, Egbert. Thank you, and over. Mr. Chair.
Okay, thank you very much, Kofi, for telling us why we are in this situation and what we are doing about our situation. The fact that a baseline survey underscored the observations that have been noted since HIV was identified in this country. The observations that people were being discriminated against, and the fact that those degrees of discrimination and stigmatization was perpetuating the continuing spread of HIV, and we all needed to do something about it. And Kofi has therefore, in his time with us, illustrated a strategic and systematic arrangement put in place to take care of this challenge. My part is to focus on the how and then the achievements under these specific strategies and activities that have been aligned to the 6 pillars in the strategic document. Next slide, please. So the whole plan to address human rights challenges is based on the recognition that we have multiple stakeholders supporting the fight against HIV. And these multiple stakeholders also exist in different sectors of our development continuum and our economic continuum, and also exist at different levels of governance in our country.
All right.
So
hello.
Hello. Nana Poku.
Yes, thank you very much. Yes, sorry for cutting in, but I think we spent about 40 minutes already. So you could please make it a little snappy so that we don't
eat
all right. Other time.
Okay, good.
Thank you very much. Please continue. Yeah.
All right, thank you. So as I said, our whole approach is multi-sectoral, multi-stakeholder, and then also multi-level through, and therefore takes care of community, district, regional, and all to the national level. And Kofi has indicated all that through his presentation with the document and policies and strategies and SOPs that have been provided to guide the effort. And so every IP working in the HIV area is expected to always make reference to these existing documents that are regularly updated by the Ghana AIDSCommission leadership, and then make sure that their activities are aligned to these strategic pillars. Secondly, the appropriate funding is always mobilized to ensure that activities can be carried through. And therefore, anybody who is willing to support the HIV agenda has something to be guided by. Lastly, next slide, please. Okay. So to date, and I believe Kofi mentioned some of these things, the fact that there's a coordinating mechanism for human rights interventions relating to all persons living with HIV, including people affected by TB, and there's a human rights steering committee. It's in place, it is operational. The monitoring tools have been developed and integrated for all partners. So there's a reference for people to follow through so that at any level at all, something feeds into the other. Lawmakers are being advocated with to improve and push for reformation. Capacity building is ongoing. Curriculum development is also a major item that has been achieved to ensure that every stakeholder working in the HIV area has appropriate information material, education material to support their particular cadres of staff or their particular audiences. And I would like to mention that a very key thing also made available is the provision of anonymous counseling channels. So these channels is another product that is allowing key populations especially to freely and conveniently engage professional caregivers and counselors, express their challenges, and then be directed to achieve their care agenda. Next slide, please. Specifically, as Kofi mentioned, the whole strategy to address human rights issues is on 6 pillars. And so these are specific achievements under each pillar. So under the coordination and advocacy of human rights interventions, Ghana AIDSCommission has been leading this whole agenda. WAPCAS is a major stakeholder. They led the human rights strategic work. And they are also supporting the revamping of the SHRAJ reporting system. And to make sure that all these things work, relevant staff are being trained as well. In the Western region and Western North, where the Care Continuum Project is currently located, we supported the formation of the regional level gender technical working group to improve sectoral collaboration and achieve remedy for abused persons. And as Kofi mentioned, the Ghana AIDSCommission LI to 2020 has also been passed to give more impetus to all these initiatives. Under Pillar 2, we talked about elimination of all forms of stigma and discrimination. As he's mentioned, and Curriculum for training institutions have been reviewed in collaboration with the National AIDS Control Program and WAPCAS. And so we have curriculum for healthcare workers to make sure that they come out of school and they're already oriented to do the right thing where key populations are concerned. And following the development of curriculum and training tools, there's been step-down training for healthcare workers, for community volunteers, for traditional leaders, and then networks of peer group leaders as well, to make sure that they all use the right nationally available tools to support the HIV response and the addressing of human rights. Then, as I mentioned earlier on, peer educators and our WAPCAS as well, the Know Your Rights campaign and the Patients Charter for the health service have all been broken down into very simple language to help educate communities and healthcare workers about the rights of clients, so that clients, when they go to facilities, also know what to expect and then they get the right service. Then the major electronic tool, the Healthy Living platform, which provides information through text messages to anybody who logs onto it. And then it also has a counseling session where once you dial in at no cost through a short code, you are directed to counselors, professional counselors, who will listen to you, take care of your issues, and then help you to address them appropriately. If they need to support you and link you to care, they do all that. Next slide. Promotion of access to justice and HR interventions. Kofi talked extensively about this. So for key populations, FSW and MSM, their PEs and case managers have been trained on human rights, on stigma, discrimination reduction, on the attitude and skills needed to ensure that they support each other appropriately. GBV, IPV issues have been outlined, and then the available remedies in country also outlined for them to make use of. And let me say that an item that is being worked on under this promotion of access to justice and human rights is advocating with the health service to ensure that when victims get to health facilities, fees that are normally demanded for the writing of police reports, those fees are waived because those fees have been identified as an impediment to access to justice. The Know Your Rights campaign I mentioned is going on. And then training of paralegals as well is ongoing. And that the pillar for removal of gender-based barriers, WAPCAS, we know, is liaising with the Ghana Police Service, the DOFSO unit, the Domestic Violence and Victim Support Unit, in dealing with these SGBV issues among sex workers. And they are working with pro bono legal teams to also offer clients legal advice. All the development organizations and CSOs are also have incorporated interventions against abuse and stigma reduction in their programs. And so at every level where they are working, you find that healthcare workers are suitably oriented. And so when you go to health facilities, you find that the health facilities have identified some of these healthcare workers as stigma and discrimination reduction champions, who make sure that these information about these issues regularly get infused into facility level meetings and engagements for all staff to be aware of and support appropriately. The Human Rights Advocacy Center is also creating an MSM human rights awareness agenda to improve access to health for MSMs in the northern part of the country. Under Pillar 5, which talks about capacity building of healthcare workers, I've already mentioned the the curriculum reviews that have been done to ensure that legal, education, advocacy strategies, etc., concerning human rights and stigma, discrimination reduction, GBV, IPV, prevention, and remedy are all provided to healthcare workers and then community actors. And so there's been extensive capacity building of healthcare providers and community actors, and then also engagement with various community members to make sure they understand issues surrounding human rights, the rights that they have to access to care and justice, so that whenever they are confronted with any problem, they can get a right remedy. Reduction, the last pillar is the reduction of stigma discrimination related to traditional and faith practices. I believe earlier on Kofi mentioned the fact that cultural and traditional practices also affect human rights for KPs. And to that end, this pillar outlines activities and strategies that are to be undertaken by every implementing partner to ensure that traditional leaders in communities, faith and traditional healers, they all are developed as advocates for human rights interventions in their communities. And this is something that the Care Continuum Project has done extensively in the Western region, where currently 39 traditional leaders and 121 faith and traditional healers have been trained as advocates. Next slide, please. So key challenges and learnings. Key challenges: getting clients to refuse home settlement of abuse, but to rather report human rights abuses for legal action. A lot of times, GBV, IPV, verbal abuse, intimidation in communities because of people's sexual orientation and behaviors. When these things happen, a lot of communities, you find relatives, traditional leaders, all coming together to try to address the problem at home so that it's not escalated to the police station or into the legal system. And this is something that we are encouraging clients not to do, because it's been leading to a continuing cycle of perpetuation of the abuses. Once people realize that, oh, this wouldn't go anywhere, we'll just settle it at home, they settle, the next moment they are doing it again. So we're encouraging clients to refuse home settlement, but to rather adopt legal action. Unfortunately, M-Friends, M-Watchers, paralegals who are providing pro bono services to participants are a few. So a lot of times you realize that they have burnout. So all projects are encouraged to look out for new M-Friends and to be able to support clients who need legal support. Friendly security services are so far limited to the friendly security service activities are so far limited to the police. Extensive training has been done, extensive changes have been done in their curriculum to make sure that they appreciate the human rights issues, and where they have to intervene for among sex workers or MSMs, they do the right thing rather than being the perpetrators of abuse. So there's the need to extend these reorientation education trainings to other services like the prison service and also the military, because sometimes the military is used to extend the support to the police when need be in terms of community crisis. Coordination at the local levels needs to be strengthened so that regions know exactly what is happening in the various districts. District health management teams know exactly what CSOs are doing, and then they can support adequately. Indeed, funding flows have been a challenge, and so scope of activities has not been extensive throughout the country. For some of these activities, we are yet to achieve national level scale up and rollout. A lot of them have been restricted to a few regions. And we still have a lot of work to do to uproot the deep-seated cultural and religious inhibitions and taboos that are leading to the perpetration of these human rights abuses against key populations. Next slide. Based on all that has been said, what has been achieved, and the process for achieving it, for us, we believe that having in place a well-resourced and dynamic national coordination unit like we have in the Ghana AIDSCommission has been very helpful. And once they appreciate all the nuances and factors that promote new infections, they put in place the right policies and continue to direct the execution of appropriate strategies and activities to achieve those policies. So that is key to success. Focus and align strategies, plans, and activities with all stakeholders and through all levels. And as I mentioned, what has been done in Ghana has been particularly fruitful because at every level, stakeholders know exactly what is to be done. Stakeholders know other stakeholders who are involved, and they collaborate and interact appropriately. Having local CSOs to extend support to these programs has been crucial to success, because at a community level, they are the ones who know people, they know the community norms and practices and taboos, and they make sure that all those things are taken care of in the execution of activities. So it's important that whatever project is designed, if it's a development organization from outside, you engage local civil society organizations and then use them to achieve community penetration and community success for every activity. And with the traditionalist and the cultural watchdog, it's important to engage them transparently, outline the scientific nature of HIV/AIDS for them to understand. And in doing so, we've been able to turn them around and get them to support the national policies and programs. So instead of traditional healers keeping patients who are sick, they rather will refer them to health facilities because they know that, you know what is happening is HIV, and then they work collaboratively with the CSO partners. So it is important that in every locality you identify these traditional leaders and engage them about HIV and then the factors that promote infection. BCC communication cannot be overstressed. We need it to make sure that everybody, general population, is all aware of what the disease is and the factors that promote it, so that rights of clients will always be respected, and then stigma and discrimination will continually be in the decline for people to be able to access services. We need to continue we believe that exposing healthcare, security personnel, local community authorities to stigma and discrimination reduction activities, GBV prevention and human rights advocacy, for them to understand the impact of these factors will make them supportive of the appropriate remedial actions. We've seen the successes of this, and we encourage others who are looking for a way to adopt these measures. And lastly, the provision of an anonymous caregiving and counseling channel. IT has enabled extensive reach for services, and to where counseling is what will help someone to identify the best resources for service. Using mobile channels anonymously, they can engage and get the desired service. Okay, next slide. And I believe we can now have the discussion.
Right. Thank you very much, Egbert, for this wonderful presentation. And thanks to Kofi too. We've had a very lengthy but packed with information section from these two presenters on what is actually ongoing in Ghana. Without much ado, I want to open the floor for questions, comments, inputs into these presentations that we have received from colleagues from Ghana. You can also type your questions or comments in the chat box so that we can together address them as it is. Thank you. You can please raise your hand, and then I think we will acknowledge you so that you can make your contributions or your comments on the section. Yes, please. I can see Madam Rosemary Kindamunda. Please forgive my pronunciation.
You
Please
got
go
it
ahead
right.
and make. All right. Thank you so much. Please go ahead and
Yeah.
then your
Thanks
comments.
to the Ghana team for a great presentation, and it's clear this is a thought out process which you are implementing. I had a few questions, but I could see some coming up in the chat. I think it is a great tactic to combine the different groups, including people living with HIV, affected by TB, together in this strategy. But we need some confidence, some assurance that the unique aspects around the criminalized population groups come out even within this package and are properly addressed. In other words, they don't drop off the package when the heat gets, the temperatures go higher. And I saw some of the questions in the chat around some raids and what have you. I think it is still silent on how much you can lobby for a change in the broader legal framework, especially for those groups, and what gains so far, so that we can say this has happened in Ghana, same colonial kind of rules, we can borrow from that. And finally, as part of the measurement, I didn't hear much about client satisfaction surveys as in one of the tools used, so that we are hearing it from the affected populations as clients rather than from our own processes. Over to you.
Right. Thank you very much, Madam, for this brilliant observation and questions. I think there are two basically, and I will start to try to answer some of this, and then the presenters will also make some contributions as well, and all Ghana team members. And I can see even the chief of party of JSI also on the call, so he can also add to it, since we're all dealing with the same situation in country. I want to look at the last, start from bottom. It talks about client satisfaction surveys. Indeed, yes, we have not done much of that officially or formally. One, because most of the clients that we have are not willing, I think the presenter also made mention of it, are not willing to come out and settle these cases of abuse in court or barriers that are brought into their way in the normal court system and the normal system. And it also makes it difficult to identify these clients. Just about 2 weeks ago, we were engaged with the Chief Justice about how the system could help address some of the abuses in the system, the human rights barriers and abuses. And one of the issues that came out clearly was that we don't have reported cases, and we don't even have the cases to use as examples, epitomes for others to follow so that they can even hasten the system. So yes, indeed, we are not doing much of client satisfaction surveys because one reason, because people are not really reporting, are not willing to go through the formal systems, and maybe out of the same stigma and discrimination are hiding. We will need to look at this and intensify our efforts in conducting client satisfaction survey. But on that, I also want to point to the fact that even before the establishment of this formal system of intervention from 2017, there were issues of programming on human rights, but this was not in a broader perspective. It was not on a large scale as we see now, though even this scale as we have now is not the best, but there were issues that were being done by partners and by the commission through other donors such as Global Fund. And right at about 2013, we had the establishment of this stigma and discrimination reporting system at SRAD. And this system had been operational and currently a little down, but it is being revamped as we have been discussing on the platform. Cases were reported, and we have data that shows the amount of data, like the quantities and amount of cases that were reported over a period. I think there was a paper that was written in 2017 in the Health and Human Rights Journal, volume 19. If we check, we will see some of these data that was collected on the quantum of human rights abuses that occurred in country. On the first issue about how well we are dealing with the broader legal framework, like solving the broader legal framework. Indeed, it is a big issue, and it's part of the advocacy section, as the presenters mentioned. The first strategic objective, coordination and dealing with broader legal framework of abuses and discrimination against persons living with HIV and key populations. These issues are done in a stepwise, non-confrontational, and continuous advocacy strategy that is used to really solve this. And I remember we sent in some papers about some years back, about 3-4 years ago, high-level papers on that issue for the review of such laws. And we still continue to do advocacy on the issue. And hopefully with time, we'll be able to come out with a better formulated laws that will help in our programming as it is. Our main aim is to ensure that everyone, irrespective of your orientation, your color, or where you live, you enjoy human rights, you enjoy the health that is needed, public health is protected, and then you have access to the needed services. Using the Universal Declaration on Human Rights that says everybody is equal and free before the law. There are about 30 of those provisions, and we are to ensure that the public health of every individual getting HIV services, irrespective of your orientation. The fundamental issue is you are a human being, and your rights have to be upheld. So I wouldn't talk so much as time is really going. I want anybody from the team to add to these questions and these comments that have been brought forth from Madam, I've forgotten the name, but so if there are any additions to this, please go ahead. team members from Ghana? If not, I can see.
Hello. I think
Hello,
that
yes.
most questions in the chat column have been addressed. The remaining one is from Humphrey, who's asking about mechanisms. And I believe you've talked about your recent engagement with the Chief Justice, etc. And and that's why in the presentation, we did indicate that a challenge is getting victims of abuse to, rather than resort to home settlement of issues, encourage them to report into the legal system and then get remedy from the legal system. Because the laws exist, we have to make use of them. And we have this Commission for Human Rights and Administrative Justice, and they have a reporting system as well, which allows anybody to make a report and follow through with the SHRAJ, who will work on it and then make sure the person gets justice. So mechanisms exist, and it's our effort to encourage more KPs to be aware of this and then make use of them for remedy. Thank you.
Thank you very much, Mr. Egbert. I can see Mr. Humphrey Ndondu. Please go ahead and make your statement, comments, or question to the House. Thank you.
Thank you, Chair, for the opportunity. This is a very exciting topic for me and a couple other colleagues that are not on the call. I have been working on the space, particularly to try and champion and advance the human rights of key populations, and particularly as they relate to access to a healthcare service. And I already want to start by congratulating colleagues from Ghana. You are miles ahead from a lot of the countries within the region that are doing programming for key populations, that you already even have a human strategy that shows that you have done a lot of thinking around exactly what you want to change and what you want to see. Earlier on, I think in the chat, we're talking about how it is going to be important for us to keep a pulse on the trends of human rights violations using documentation and surveillance, because we need evidence for these violations that they are occurring in the communities. We have lived a lot in context where there is even denial that key populations exist. So if we could establish mechanisms by which colleagues feel safe enough to report violence or incidents of abuses, that would be great. That's why I wanted to call for you to have mechanisms from community systems that ensure that colleagues can access platforms for redress. The challenge you speak to around individuals are unwilling to go through with the justice system or follow through a litigation process is because of the lived experiences key population communities have faced over time. Access to justice has always been a challenge, and where we have tried to access justice, it has been levied with vicarious trauma of you're going to report, you are vilified upon arrest, you are vilified as upon detention, you are vilified within the courts as you are being released and discharged. Your issues are in the press, and the whole world knows about what a shameful person you are. So this kind of narrative still exists in a lot of countries. And where we are seeing a progress of laws that have turned in terms of sexual orientation and gender identity and expression, for example, in South Africa, that has had progressive laws for a long time. In Angola, in Mozambique, in Botswana, we are still seeing that there is a narrative of violence that continues to perpetrate or to continue to happen in this context. So there is a lot more than we are doing with the law that we need to do in terms of conscientizing a broader community of healthcare workers and a broader community of people at home, of religious leaders, of parliamentarians, etc. We have these precedents around how the laws can be changed. We have a resolution of the African Commission on the People and Human Rights, Resolution 275, that was passed in 2014, that speaks to, that encourages country to desist from criminalizing individuals on the perception of a real or imputed sexual orientation and gender identity and expression. And we can use these as tools to start a conversations locally, wherever we are, to change this narrative. And the public health has always been a soft spot for us to navigate this conversation around ensuring a health rights. And it's quite an exciting time that we're seeing governments, national AIDS councils, having these conversations around creating platforms where we are the ones pushing the agenda for documenting and mitigating against human rights abuses. I don't want to give another lecture. Thank you so much. It was an exciting session. I got too excited. Thanks.
Thank you very much. That is wonderful. We appreciate the contribution and then the admonition of ensuring that all human rights are upheld. Yes. Are there any additional comments, questions from the chat and from anybody on the call, please? I don't see any hand up, but we still have Mr. Humphrey's hand, but I'm sure maybe it's the previous hand.
Apologies, it's an old hand. Let me lower it.
Right, that's fine. So we can quickly go through the points on our screen. What surprised or impressed or concerns do you have about Ghana's approach? What surprised, impressed, or concerns you about Ghana's approach? Anybody, please?
Hello.
Hello? Please,
Yes,
we can hear you. Go ahead, please.
I mentioned what impressed me, the deliberate effort to program for human rights and to take it as a package for all groups, which I believe makes it easier to negotiate through the policy framework, but at the same time, through the public health approach, provides opportunity to focus on all groups. I raised the issues around the possibility of any group falling through the cracks, which was answered as my concern. And I believe we can learn a lot, because in Uganda, we basically have a particular focus on KPs. And yes, there are great improvements from 10 years ago, but sometimes you take 3 steps ahead and 2 behind, depending on the political mood. But I'm looking at a situation when, as part of our learning, when do we think we are likely to move from the HIV platform and address the issue of human rights for these groups as human rights, as beyond the public health approach? Perhaps as we continue with our learning process here, we may get some more ideas around how we can do that. Over.
Thank you very much for reaffirming some of the issues. When do we move and ensure that we're not just providing the services, but ensure that services are provided based on human rights approaches based on public health approaches. And yes, with the example that I have said, I have observed that even proud to try to structure these interventions from 2013 all along to about 2017, there was some human rights interventions in a smaller scale, scattered, made as it is. And currently we are looking at how to bring all this together at the national level, at a bigger scale, and then see how we can have it implemented across the breadth and length of Ghana. Thank you very much. And another approach that I really have seen is that it started right from bottom-up approach and getting every sector involved. When you look at the strategy that has built, it has been built or have been developed based on experiences from the past. And it touches on every aspect. It is not a one-size-fits-all. We look at all the strategies that can be dealt with or can be worked on in order to achieve our aim of ensuring that everybody is not left behind and we achieve the elimination of HIV and AIDS in the country. Thank you very much. I think we spent so much time. I don't know whether there are further questions. How can cross-country learning be applied practically? And then the last one says, which conversations can now take place across or within countries? Are there any thoughts, comments, issues on these whilst we try to run up and hand over to the organizers? Any comments, contributions from the Ghana team members, and then from all participants as it is?
We thank you for your patience and careful listening of everything to be able to participate fully. We are grateful.
Yeah. I also want to add my voice. We are very, very grateful for your patience. Sorry we couldn't start exactly on time, but then we really are very, very grateful. Yeah.
Right. If there are no further comments, I can't see any hand in the chat. I can't see any additional issues. I will hand over to the SSLN team. Or the next steps here is for participating, countries to have their own takeaway. Oh, wonderful. So, SSLN, do we have countries having their own takeaways, broadcasting this, or they just have to keep to themselves?
Dr. Nana, if countries would like to share, they are welcome to do so. I think some have already shared previously, so we can see if there's anything further that they wish to share publicly. Otherwise, we can share some next steps, perhaps.
Oh, okay. All right, Kerry. So if it's so, then we can share some next steps with the team, and then we can end the section.
Perfect. Thank you very much. So colleagues, thanks once more for your participation and to the Ghana team for leading us through this really valuable session. In terms of some of the next steps, as the South-South Learning Network, we will be sharing the presentation from today as well as the recording of the session. We will also consolidate and share many of the documents that were referenced throughout this presentation and share it for you all to kind of reference and refer to at your leisure. We are also offering to support any bilateral engagements, should anyone on this team wish to engage further with the Ghana team or across countries as well. So please feel free to reach out to us. We can help to facilitate that, if you will. And perhaps before I hand back to Dr. Nana to close, we'd just like to ask for literally 1 minute for you to just capture some of your feedback on the session, as it's helping us to improve these link and learn sessions and better respond to the needs of countries. So Lulama, perhaps I can just ask you to launch our final poll. It really will only take 1 minute. And if I could ask colleagues, please, to kindly share your feedback. And also you are welcome to share any written feedback with anyone from the South-South Learning Network on these sorts of sessions. Lulama, have you shared? Will you just alert me because I'm unable to see?
Sure, Carrie. Yes, I've shared and colleagues are already starting to vote.
Thank you. So just for 1 minute, we can capture some of the feedback before we close out. Lulama, how are we doing? Are we able to close and share?
Yes, Carrie, actually, we've just reached a minute, so I think it's a good time to share in the poll and share the results.
Thank you very much, colleagues. So Dr. Nana, that is all from us. I'll hand to you as our host to formally close the meeting. Thank you very much.
Thank you very much, Madam Carrie. We want to take the opportunity to thank everyone on the call and emphasize that Ghana is still on the path of implementing our strategy. We are just about a year into this strategy. The strategy's last is for 2020 to 2025. And we know that with the help of all partners and everybody, we will be able to implement to the full so that we see the end of HIV and AIDS in Ghana. And we attain epidemic control, and we'll be in a country where every person's or diligence rights is upheld. Thank you for listening. We are open to more comments. We are open to learning from you as well. And we are always welcome to Ghana. Thank you. And the team is very grateful to the SSLN team and all the countries that are on this platform. Thank you, and do enjoy the rest of the week. Over.